Let's talk about Wilson disease. So this is a disease caused by a genetic defect in the intracellular copper transporter ATP7B on chromosome 13. Now this gene is involved in creating a protein that regulates biliary copper excretion, and as a result of this defect, the excretion of copper is impaired, and so there will be an accumulation of copper in the body. This protein is also involved in the formation of ceruloplasmin. So as a result of this defect, then copper will accumulate first in the liver and the hepatocytes, and then in the brain and cornea. There is a autosomal recessive inheritance, and the age of onset is variable, though generally it takes a few years before you start manifesting the symptoms. So for clinical features, for the liver, you may have abdominal pain, hepatomegaly, cirrhosis, ascites, jaundice, hepatic encephalopathy, or acute liver failure. For the cornea, commonly tested are Kayser-Fleischer rings, which are found in 95 to 98% of patients with neurologic or psychiatric symptoms, and these are best detected by slit lamp examination with ophthalmology. So other clinical features can include neurologic symptoms such as dysarthria being the most common one, but otherwise the presentation can be variable, including dystonia, tremor, Parkinsonism, cognitive impairment, ataxia, and seizures. There are usually some psychiatric manifestations too, such as mood disorders, irritability, personality changes, and psychosis. Coombs negative hemolytic anemia can be found too, and occasionally it is also the presenting symptom. For evaluation, a serum ceruloplasmin less than 20 is suggestive of the disease, and a 24-hour urine copper excretion is also elevated. The reason that it's elevated is because when you're not able to eliminate copper in the bile, then the body will try to eliminate it in the urine. There can be a low serum copper unless the patient's in acute liver failure, in which case the serum copper will be high. There can also be transaminitis with an AST over ALT ratio of 2, and a CBC is generally done, and if there's anemia, a Coombs test can be sent to see if this is a Coombs negative hemolytic anemia. Now, once you suspect the disease, you can confirm the diagnosis with either genetic testing for ATP7B mutations, or the gold standard is a liver biopsy with high hepatic copper concentration. Ruling out other diseases is also important, and an MRI brain is usually done, and that will show T2 hyperintensities that is most commonly in the putamen, but otherwise in other parts of the basal ganglia and midbrain. For the treatment, D-penicillamine is the treatment of choice. It chelates copper and binds it, and it's excreted in the urine. So the urine copper concentration should be increased after starting this medication, and monitoring it is a way to determine if the treatment is working. If neurologic symptoms worsen, then penicillamine is usually stopped, and then an alternative medication such as trientine is started, which is also a copper chelator. Important in stopping reaccumulation of copper is maintaining a low copper diet, as well as oral zinc. Zinc decreases copper absorption in the GI tract. For cases with someone with advanced liver disease or acute liver failure, a liver transplant can be done. For prognosis, Wilson disease is universally fatal if untreated. Most patients will die from liver disease. In addition, they'll also have an increased risk of hepatocellular carcinoma, and early detection and treatment improves mortality. For that reason, screening is important. For someone with Wilson disease, screening the first-degree family members will lead to earlier treatment, and they can be tested for mutations in the ATP7B gene.